University of California, Irvine, and their Alzheimer's Disease Research Center there. Dr. Liana Apostolova from Indiana University and the Alzheimer's Disease Research Center there. And we have Dr. Alfred Sandrock, Vice President of Research representing Biogen Pharmaceutical Company. He's going to talk to us about the newly released medication Aduhelm, which has been approved for treatment of Alzheimer's disease. In the next few minutes, you're going to participate in an exercise demonstration with our favorite Mr. John Lewis. And following John's exercise, you'll hear from Dr. Hepburn. So sit down, take a break, get ready to jam. Thank you so much for tuning in, and we'll look forward to hearing from you. Please make sure that you answer the questions in the polls before and after. Thank you.
Hey, I'm John Lewis, and I want to welcome everyone to the 21st Emory Brain Forum. Today, if you haven't, make sure you have a sturdy chair. Make sure you have a water bottle, towels, anything you want around the house. So we're going to get started in 5 seconds. Get in that chair because I'm going to take you all around the world. We're going to work on that core, them shoulders, those hips, and that cardio, because cardio is life. Y'all ready? Let's warm up. Okay. I just want a little tap. Tap, 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 tap. Come on. Now, little watch. Come on. We warming up them hips. Remember, you can go at your levels. Watch it, watch it, watch it. Let's go. Give me that hip, and we get that waistline. Let's go. 1, 2, ready, switch. Let's go. Come on now. I need y'all going. Come on, come on. And if you need to just take a little short step, you can. Let's go. Okay. Ready. Nice and smooth. Because we're telling that body, we about to go to work. Come on now. Okay, okay. Ready. Okay. Now we get those hamstrings. Ankle. Ready. Okay. Feet together. And twist. Y'all see how we engage in that waistline? Remember, go at your level. If this your level, let's go. Let's go. And if you need to take a break, take that break and get back in. And rest. 1 minute. Here we go. Let's get. Okay. Give them hands.
Can't be sleeping,
Elbows up.
keep on waking,
Come on.
without the woman next to me. Guilt is burning,
Here we go.
inside I'm hurting. This ain't a feeling I can keep.
Come on.
So blame it
Get 'em up.
on the night.
Get 'em up. Get 'em up. Get 'em up.
Blame it on
Hey,
me.
hey, hey,
Blame it
hey,
on
hey,
me.
hey. Let's
Blame
go.
it on the night. Don't blame it on me. Don't blame it on me.
Here we go.
Blame it on the night. Don't blame it on me. Don't blame it on me. Don't blame it on the night. Don't blame it on me. Don't blame it on me. Don't blame it
me. Here we go.
Been going around and telling stories.
Let's go to the islands.
Boy, you know me. And about this year, mother girl.
I need that waistline.
No. Give me some bass, let me sing something first.
Here we
You
go.
go, so. Oh, na, 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 na. Oh, na, na, na,
Right here.
na, na. Oh, na, 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 na. Oh, na, 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 na. It's all about Romy. And the big fat sister, now you're me. You do what them claims.
Do that waistline. We working that lower back. Do side on fleek. Let's go. Other way. Come on. Come on. Go. Let's go. And breath. We gonna keep it moving. There we go.
A few days before he turned 80, he was sitting out back in the rock.
Give me that
Said,
name.
what you been up to lately?
We create circulation right now.
And in between sips of coffee, he poured this wisdom out. Said, if you want my 2 cents on making a dollar count, buy down, find a one you can't live
Give me the
without.
real.
Get a ring with your knee, hit the ground. Do what you love, but call it work.
And rest.
Money.
FAANzone.live. That's www.FAANzone.live. And we have videos for you. Thank you. And I'm John Lewis. And see you later. Bye.
Bye, John. Thank you, John. I hope everybody's energized and ready to sit in here and get some really, really good information. Our next presenter is going to be Dr. Allan Levey. He is the director of the Goizueta Alzheimer's Disease Research Center and founding chair. He's also director of the new Brain Health Personalized Medicine Institute here at the Brain Health Center. He's also the Betty Gage Holland Chair for Neurology. Most recently, he has stepped down as department chair for the Department of Neurology here at Emory. At this time, Dr. Allan Levey. Allan?
Well, thank you, Monica. As always, this is the 21st time I'm able to thank Monica. It's our 21st annual Brain Health Forum, and it's a real pleasure to be here. I'm not really presenting today. I'm just here to welcome you and to thank you. The thank you first and foremost goes to the more than 500 participants on the call today. This is extraordinary. And so one of the best, if not the only good thing that's come out of COVID, other than a vaccine, is our ability to reach so many people. And so I appreciate touching all of you and hope that you will enjoy the meeting this afternoon. Also want to thank my colleagues here at Emory, Dr. Jim Law, Ken Hepburn, who will be presenting. And then, of course, Monica, Cornelia, Crystal, and our whole team that has just worked tirelessly and done such a great job putting together these presentations. So thank you all. Our session today is, as you know, about aging, Alzheimer's disease, and early detection. And boy, what a timely, important theme it is. This is, we know what's ahead of us. Alzheimer's disease and related disorders are just one of the greatest challenges we have for all of humanity. And all of us are privileged to take part in this. In so many ways, early detection is really just the first part of what we need to do. Even today, as we're going to hear from Dr. Sandrock about Biogen's drug, we know this is just the beginning and there are more treatments ahead. Nobody's going to get treatments unless we can diagnose the disease. And so that's a very important area of research that many of you who contribute to the research programs here are helping us. And you're going to hear a little bit more about that from Dr. Law when he talks about the Emory Healthy Brain Study and our efforts to detect early predictive biomarkers, even in pre-symptomatic disease. And you're also going to hear from Dr. Ken Hepburn about caregiving, and it just distresses all of us here. So every day when we're in clinic taking care of patients and realizing that sometimes years have gone by before they've reached a diagnosis. And what we're doing is depriving individuals the opportunity to learn about the disease, to help mitigate the challenges that might lie ahead for them, and take advantage of empowering people with the resources that they should have access to today, making sure those are available to everybody. And speaking of everybody, so much of our mission at Emory and the Goizetta Alzheimer's Disease Research Center is to make sure that the research is applicable to everybody. And so we've had for many, many years a priority to make sure that people of color are better represented in research, and that we better understand the special research needs, that we build the trust that is much needed to engage people in a trusting environment to participate in research. It's crucial because we know from the treatments, the clinical trials that have been ongoing, we've had vast underrepresentation of African Americans and other Latinos and other minorities. And as a result, as treatments are developing, we don't know if they're going to be as effective in all individuals, and we certainly don't know if they're going to be as safe as they should be in all individuals. And that can't happen. A future where everybody gets access to the best treatments really depends on you and us working together to make sure everybody's engaged. And again, the first step is making sure that we can diagnose Alzheimer's disease and all the complex conditions that come with it, including vascular disease, Parkinsonian problems, and the like. So we certainly have our work, and we appreciate your partnership in helping us. And then lastly, I just want to thank in advance our just outstanding colleagues who are joining us today. We participate in a national and really global effort to move research forward. You're going to hear from Dr. Josh Grill about the A4 study and early intervention. And then you're going to hear from Dr. Sandrock about Biogen and their latest work. And then our colleague from Indiana, Liana, Dr. Liana Apostolova, who is going to talk about very aggressive early onset form of Alzheimer's disease in the national trial that she's leading. And Emory's involved in all these activities. And so we hope you enjoy the rest of the afternoon. So again, Monica, thank you very much for your leadership in helping move this forward, and turn it back over to you.
Thank you, Allan. And thank you to the greater than 535 people who've already turned in to hear us this afternoon. So at this point in time, I'd like to turn the next part of our program over to Dr. James Law, who's the principal investigator of our Emory Healthy Brain Study. He's also the clinical core director for the Goizetta Alzheimer's Disease Research Center, also vice chair of the Department of Neurology. At this time, I'd like you to hear from Dr. James Law. Again, he's our clinical core director and also director of the Emory Healthy Brain Study, which you will be hearing a little bit more about in his presentation. Dr. Law. Technical issues, but we're right here with you.
So first of all, I want to make sure that that we're all on the same page. Let me just step back for a minute. This is sort of how I envision what happens when I'm seeing patients in my clinic, and I tell them different things. If I tell somebody that you have MCI or mild cognitive impairment, they're like, yeah, that doesn't sound so good. And then if we talk about somebody having dementia, that sounds really not so good. But then if I say the word Alzheimer's, all of a sudden the scare factor goes up astronomically. So I want to make sure we understand what we're talking about when we talk about these terms. So first of all, what is the difference between Alzheimer's disease and dementia? That's probably the single most common question we get. And so one of the analogies that I use is to tell people, well, you know, if you say you have dementia, it's kind of like saying, I have a headache. And then whether it's mild cognitive impairment or mild dementia or severe dementia, maybe just a consequence of how bad that headache is. So I just got a little tiny headache, and now I've got a terrible migraine headache. So that's milder or more severe. But just saying that I have a headache doesn't tell you why you're having the headache. So it may be that you've got an aneurysm that's about to rupture, and that's a very specific cause for a headache, and that could be a problem. Or you could be Tiger Woods and you were a bonehead and your wife took a 7-iron upside your head. That's a whole nother reason for a headache. But either of those things can be the cause of a headache. So when we say somebody has dementia or memory loss, that's just a symptom like having your head hurt, but it's not saying what's causing that problem to occur, the memory loss or the dementia symptoms. And regardless, and there are lots of different things we'll talk about what can cause cognitive problems, memory loss, and dementia. But if it's due to a degenerative process, something that's going to get worse over time, they all follow a similar course. So early on in the course of the disease, the symptoms may be very mild. That's where this mild cognitive impairment comes in. And during that phase of any illness, while there may be a clear decline from your normal baseline, the impairments or the difficulties that you're having are typically mild. And many of these patients who, even though they had some decline, they're still functioning normally. I've had patients who have symptoms of mild cognitive impairment that are still practicing law, medicine even, and managing companies despite these difficulties because the symptoms are so mild. The problem is when we're talking about diseases that gets worse over time, over the course of time in early stages when things have gotten worse and there's some worsening of memory and other thinking problems, and you need a little bit more support with things, that's a little bit more problematic, but quality of life at these milder stages can still be excellent. But unfortunately, for those of us who know and either care for or have experience with friends and family and other loved ones who have more severe dementia, there's a much more profound loss of abilities, sometimes behavioral problems, increasing burden on those around the affected individual. And then in late stages, it's really a devastating loss of quality of life. So no matter what the cause is that we're talking about, when things are progressive, when there's a disease that gets worse over time, the decline in functional ability and the worsening of quality of life is what the big problem is. So I want you to remember this. I'm going to come back to this. And the diseases, when we talk about Alzheimer's disease just happens to be the most common disease that causes progressive memory loss and progressive dementia symptoms, especially in older adults. But it's certainly not the only one. There are many other diseases. This isn't meant to be comprehensive, but there are many other diseases that can cause similar deterioration, but it's caused by a different underlying process, different changes in the brain in each of these conditions. And Alzheimer's disease is the one that we've really chosen to focus on because this is far and away the biggest problem and the most common reason why older individuals suffer from memory loss and progressive deterioration. And so what do I mean when I say somebody has Alzheimer's disease? So this is a famous picture of a lady named Auguste Dieter, who was the first patient who was studied by Dr. Alzheimer back in the early 1900s. And you see she developed symptoms at a very early age, in her early 50s. But she had those symptoms that we currently recognize occurring in people who have Alzheimer's disease. So she had progressive memory loss. She started to become suspicious that her husband was being unfaithful to her. She had worsening language abilities and progressive functional decline, and she died at the ripe old age of 55, which is obviously very, very young. And this fellow, Alzheimer, studied her during her life and examined her brain after her death. And he described, these are not pictures from his drawings, he actually drew line drawings of what he saw. But these are the features that he recognized that we still recognize today as the key changes that occur inside the brains of individuals with Alzheimer's disease. And so this center blob here is something called an amyloid plaque or a senile plaque made up of a protein called amyloid beta or A-beta. And these dark triangular looking things are abnormal proteins that are accumulated inside a brain cell. So this triangular cell is actually a brain cell inside a person's brain. And this abnormal protein called tau has accumulated. So these plaques and tangles are found 100% of the time in anybody who has suffered decline and died because of Alzheimer's disease. If you look at their brain under a microscope, you will see these two changes in 100% of cases. And one of the important advances, so at the time that Alzheimer was meeting and studying Frau Dieter, Ms. Dieter, Alzheimer's disease was not very well understood. However, the process of age-related memory changes, what people used to call senility or hardening of the arteries, these things were known since antiquity. But what has changed in recent decades is we've really learned to approach Alzheimer's disease as a chronic condition. And so when I say a chronic condition, I mean like a chronic medical condition like heart disease or cancer. And so if we think about this in terms of heart disease, you don't all of a sudden wake up one day and have a heart attack. That process was evolving for many years as the blood vessels that supply your heart gradually became more and more blocked by these abnormal things that occur in the coronary arteries. And eventually, when the blockages of those arteries become critical, there's not enough blood flow to supply the heart's needs. And that's when chest pain or angina or heart attack occur. And so this is a chronic process that occurs over many years. And what we've come to understand about Alzheimer's disease is it's exactly the same thing. So out here on this graph, out in this right end side of this is where people are having symptoms of memory loss and progressive dementia. So this curve is now flipped compared to what I showed you, with the line going up indicating increased symptoms, clinical symptoms. And what we've come to realize is that the changes, the plaques and tangles that I just described in the Alzheimer's disease brain, those changes are accumulating for up to 20 years before somebody actually experiences symptoms of Alzheimer's disease. So just like in heart disease, the blockages of the coronary arteries may be evolving for 10, 20 years before somebody has a heart attack. And the same thing applies for Alzheimer's disease. We know that these changes occur inside our brains completely silently. Without causing any symptoms, and that may happen starting up to 20 years before somebody actually shows symptoms and may be clinically diagnosed with mild cognitive impairment or dementia because of underlying Alzheimer's disease. So this is a real challenge, but it's also a real opportunity, because over the last couple of decades, we've also developed tools that allow us to detect the presence of those plaques and tangles inside the human brain without having to wait until somebody has died. So many years ago, people used to say, Well, you can't really be sure it's Alzheimer's disease until you're dead and you look at your brain under a microscope. That used to be true, but that is no longer true because we have these tools. And these are pictures from a special scan. So these are pictures of a brain. And on the left here is an individual who has Alzheimer's disease, has symptoms of Alzheimer's disease. And what we're looking at is injection of something into the bloodstream that gets up into the brain. And if there are amyloid plaques inside the brain, this dye sticks to those areas and gives off a signal that we can detect. As opposed to a healthy person with no amyloid plaques, and you don't see any of this staining or this binding of this dye. And so we can clearly discriminate that. And then also those tangles, this is a front view. So these are side views of the brain, and this is a front view of the brain with the brain cut sort of vertically. And you can actually detect the presence of that tangle pathology using a different dye. And so these are tools that we have currently that we can use to visualize these pathologies inside the human brain. But what I'm showing you here now is another scan from a healthy person, a normal person without any memory problems, without any functional limitations. And you see that this person also has a substantial amount of the plaque or amyloid pathology. And this is when I say that we can detect the presence of this pathology many years before somebody develops symptoms, we might see a scan like this in somebody who already has significant memory problems and symptoms of Alzheimer's disease, or we may see this in somebody who doesn't have any symptoms of Alzheimer's disease. And so this is sort of the inflection point where we're working right now. And so the Emory Healthy Brain Study has only one goal, and that is to be able to make a prediction. So if I can detect the presence of these pathologies inside the brain of a healthy person, I need to be able to answer two really important questions. One is, am I ever going to get Alzheimer's disease? When we look at the brains of older, healthy individuals who died without any memory problems or symptoms of Alzheimer's disease, and a large proportion of those individuals, if you manage to live into your 80s or 90s, in a large proportion of healthy individuals, we will see Alzheimer's pathology, but they never develop symptoms during life. And so it's really important to be able to answer this question. Am I ever going to develop symptoms of Alzheimer's disease? I don't really care if I have a brain full of plaques and tangles if I don't have any symptoms being caused by those. And then secondly, if I'm going to develop symptoms of Alzheimer's disease, when is that going to happen? Because if I detect the presence of these changes in the brain of a 75-year-old, but I know that they're not going to develop any symptoms for 20 years, then what should I do to that person? I should leave them alone. I shouldn't go and do crazy stuff that might potentially cause harm if they're very unlikely to develop symptoms during their lifetime. So this is the sole purpose, the only reason why we're doing the Emory Healthy Brain Study.
Okay, thank you so much, Jim, for that presentation. At this time, we have a number of questions that have come through our chat that Dr. Law and I are going to answer. So Dr. Law, you want to read off that first one you got?
Yeah, so I think this is, was a question related to Aduhelm and the high costs associated with Aduhelm that went into the Q&A. How can everyone gain access if treatment costs are so very high, even with insurance? I almost want to punt this question to Dr. Sandrock, who's going to be here from Biogen with us. The reality is that we don't yet know what the coverage is going to be like. Medicare and CMS is going to be the first one to have to step up and decide what they're going to do about paying for the costs, not just the cost of the drug, but the infusions and then the safety scans that have to be done. So we think that within a few months, CMS will render a decision on that and let us know what they're going to do, and then insurance companies will follow suit. But until that decision is made, we're just kind of in limbo in terms of understanding what the accessibility is going to be like. And then there was another question that came, does a patient with dementia mean they have Alzheimer's? And again, this is such a confusing issue because the terminology is used very kind of sloppily. But again, as I was saying about the headache analogy, just saying that somebody has dementia is not a disease. If somebody has symptoms of cognitive decline that's interfering with their normal functioning, they by definition have at least mild dementia. And Alzheimer's disease as a specific entity that has those plaques and tangles and those tests that we can do based on imaging and spinal fluid testing. We know based on those tests, as well as from a lot of studies looking in brains of people after they've died, that Alzheimer's disease is a very specific condition that's associated with very specific changes in the brain that can cause dementia. So Alzheimer's is one, a very common, unfortunately, but one of many different reasons why people may develop dementia. And then another question that came in, my mother's doctor believes she has Lewy body dementia. Do you think I can still benefit from the Alzheimer's information? And the answer to that is absolutely yes. There are some features that are unique and different for Lewy body dementia, which again is another relatively common condition that can cause progressive cognitive decline. With Lewy body dementia, it may also be associated with other specific symptoms like Parkinson's-like movement problems, falls, visual hallucinations, some unusual sleep behaviors. But one of the things that we've come to appreciate, Dr. Levey alluded to Alzheimer's and related disorders in his introductory comments. And the fact of the matter is, I said that Alzheimer's is the most common. It's the biggest reason why we have this problem. But there's a huge overlap across these conditions. So I don't want to confuse anybody, but when we look in the brains of individuals after they've died, and during life, we thought that person clearly had Alzheimer's disease or clearly had Lewy body disease. In their brains, we might see evidence of both pathologies. And then there are other pathologies that are being recognized. So even though each of these are distinct diseases, just like the notion of a rising tide lifting all boats, as we learn more about Alzheimer's disease and develop more effective treatments for that, that is going to have a spillover effect. And certainly the knowledge and understanding related to Alzheimer's disease is beneficial for those with related disorders as well. And what the last question that I had printed up for me was, what is the average cost of Aduhelm, and do most drug plans cover any of these costs? And again, that's an answer that we don't have an answer to that question. Biogen has initially introduced the drug with an annual cost of $56,000 a year. And so we don't know exactly, that's about all we know. We don't know what the coverage is going to do, what the insurance companies or Medicare are going to do. Crystal, were there other questions?
Yes. Which is preferred, CT or MRI for diagnosis?
We prefer,
Repeat.
the question is, what's preferred, a CT scan of the brain or an MRI? I'm primary care, so I'm going to tell you we should have an MRI, right, Dr. Law?
Yes, ma'am.
For those of us in the audience, it's like I get a CT scan of the head. Well, a CT scan of the head is not nearly as specific or as detailed an exam as a brain MRI. Even more important, and more importantly, diagnostic of definitive Alzheimer's, is to have an amyloid PET scan. But we can't afford that. Nobody can afford that. It's only a tool that's available through research.
Memory loss due to stress and anxiety, is that a part of early onset of Alzheimer's?
Okay.
Repeat the question, please.
Okay, the question is, if somebody's under a lot of stress and they're experiencing a lot of anxiety and they're starting to have difficulty organizing their thoughts and memory, is that early onset dementia? No, that's likely anxiety and depression, which can be managed and can be treated, but you have to look at it accordingly. Get to your doctor, get an evaluation to make sure that that's what we're looking at. So stress and anxiety and depression can make it such that your brain doesn't work like it's supposed to, and maybe you have difficulty making decisions, but that does not mean you have early onset Alzheimer's. That means you have anxiety and depression that needs to be managed.
However, I will say there is some evidence that these mood disorders can play, again, just like my answer to the Lewy body question, there's a lot of evidence that these mood disorders, anxiety, depression can intersect with Alzheimer's disease biologically. So they can have an impact on both the manifestations in somebody who has Alzheimer's, or potentially by not managing our stress and anxiety and depression well, And we may put ourselves at risk later on of having greater risk of developing Alzheimer's and related disorders. So those are things that are really important to attend to for very basic reasons.
Okay. Thank you, Jim. Thank you. We have some more questions and we will continue to answer them in the chat as we go along. At this time, I'd like to bring on one of our coordinators, Ms. Danielle Moore, who's going to talk about the Emory Healthy Brain Study, which is our longitudinal study that we're offering here at the Goizueta Alzheimer's Disease Research Center. And you can be anywhere from 18 to 1,000 as long as you enroll.
That's for the healthy aging study, but for the healthy brain study is for 50 and older, and it parallels what we're doing in the ADRC.
It's your opportunity to participate in research. Danielle?
Hello, everyone. I'm Danielle Moore, and I am one of the people responsible for recruitment for the Healthy Aging Study and Healthy Brain Study. So I'm just going to share my screen. Okay, so why participate in the Healthy Brain Study? Every 66 seconds, someone in the US develops Alzheimer's disease, and the Emory Healthy Brain Study aims to identify the biomarkers that will allow us to predict and ultimately treat this disease. But we need participants' help to do so. And so as far as the participant selection, the age group for the Healthy Brain Study includes individuals aged 50 to 75. And for the Healthy Aging Study, it is open to individuals 18 years and older. Those eligible for participation will have no cognitive impairment diagnosis and no condition incompatible with long-term longitudinal follow-up. You come in for your visits for the study every 2 years. And so that's why we usually make sure that you don't have anything that would interfere with that. And participants who are currently pregnant or nursing will not be eligible for imaging procedures. As far as the recruitment process, it's very quick, very simple. You'll begin by registering for the Healthy Aging Study at healthyaging.emory.edu. Following your registration, a recruiter will be in touch with you shortly in order to ask you a couple of eligibility questions and just to confirm that you're actually eligible for the study. And then you will be scheduling your visit with a recruiter every 2 years. And we will touch base with you and keep up with you to remind you every 2 years when you are due for your next visit. As far as the visits, it consists of 3 different visits. You're going to have your teletesting visit, which is approximately 2.5 hours. This is basically where we're just getting your consent, your signature on the consent documents, and you will do your cognitive memory assessments, so kind of like memory tests. The next visit is going to be your MRI, which is an MRI brain scan. And lastly will be your fasting visit, which consists of vitals. We take blood, we do a lumbar puncture and a cardiovascular assessment. We get a lot of questions about the lumbar puncture, but it's essentially a needle in your lower back where we collect spinal fluid to get a little more information on your brain health. Okay, and then here's my contact information. If you have any more questions about recruitment for the study, or if you are interested in participating in the study, I will leave this information in the chat as well, but I'm just going to keep it up for a second so that you can screenshot or take a photo or write down my number. All right,
Thank you so much, Danielle, for that introduction to both the Emory Healthy Aging and Emory Healthy Brain Study. Right now, our very next presenter is going to be Dr. Kenneth Hepburn. He is director of our Outreach, Recruitment, and Education Core here at the Goizueta Alzheimer's Disease Research Center. He is also professor at the Nell Hodgson Woodruff School of Nursing here at Emory. He's director of our Outreach, Recruitment, and Education Core, and also co-director of the Emory Roybal Center for Caregiving Mastery. Dr. Kenneth Hepburn.
Thank you, Monica. It's good to be with everybody again. I'm going to talk about designing a just right challenge for a person living with dementia disorder. Well, in the meantime, because this is going to be part of the talk before the slides come on, I'm going to give you a puzzle, and I've used this puzzle before. Those of you who are not in the Atlanta area, the Chattahoochee River runs through Atlanta and all the way down, I think, into Florida. So I want you to imagine that you're standing on the banks of the Chattahoochee, and you have a chicken, a fox, and a bag of grain, and there's a rowboat there. And you have to take the chicken, the fox, and the bag of grain across the Chattahoochee to the other side. But you've got to do that following these rules. You can only take one thing at a time across. You cannot leave the chicken alone with the bag of grain, and you can't leave the fox alone with the chicken. So that's the puzzle. Keep that in mind. We'll get back to that in just a minute. So what I want to talk about then is designing a just right challenge. People who are caring for a person living with dementia illness are guiding that person's day. And the kind of hope is that the guidance will provide opportunities throughout the day for the person to become, meaningfully and pleasurably, enjoyably engaged in things. And to do that, you have to be able to design tasks and activities that are just right for the person. So next slide, please. When you think about doing something, it doesn't matter what it is, up to and including doing this kind of video conference we're doing, there are three key elements to doing things. You have to maintain the purpose of what you're doing. You got to keep in mind what you're about. And then, for the most part, you have to do things in order to accomplish the purpose. And at a much more elementary level, you've got to be able to use whatever tools you have you need to be able to use to get the task done. So go to the next slide, please. In dementia and dementia illnesses, these key elements, purpose, order, and use, are lost in sort of overlapping and progressive order. So first, the person's capacity to keep a task's purpose in mind begins to dim and erode, and gradually it's lost. As that's occurring, the person's ability to do things in order is also eroding. And as that's happening, person's ability to use things appropriately is also eroding. So this brings us kind of back to the puzzle, because if you think about it, if you don't keep the order of things in mind and the rules, something or somebody is going to get eaten. The chicken gets eaten, or the grain gets eaten, and the whole task is botched, right? So if you're in this situation, what you want to do is take the chicken across first, leave the chicken on the other side of the Chattahoochee, and then row back, and you get the bag of grain, and you bring the bag of grain over, and you leave it there, but you take the chicken back with you across to the first side. And then you take the fox over, come back and get the chicken. And since you're there, everybody's going to be safe. Unless you remember the rules, that isn't going to work. Unless you do things in the right order, it's just not going to work. And if you can't row the boat, nothing's going to happen. So purpose, order, and use. Now go to the next slide, please. If you think about a dementia illness, next slide, please. It progresses in stages, and the stages are not, there's no rule for when the stages occur. Could I have the next slide, please? Well, okay. If you think about getting somebody involved in a task, a just right task, there are three elements that you really want to keep in mind. First, what does the person like to do? I mean, play into the person's strengths and the person's likes. This could be how does the person like to get dressed in the morning, or when does she like to get dressed, or how does she like to wash up? How the person used to do things, what the person used to enjoy. Was it knitting? Was it woodwork? Whatever. Then you have to decide what should be the nature and setup of the task itself, and how do I provide support for it? So next slide. When you think about a task, it's got lots and lots of dimensions, right? It's big and small. It involves complex or not so complex skills. It's done in one place or it's done in multiple places. It can take a long time or a short time. So these are all part of a design of a just right challenge. You have to think, what is the task I want to give the person? But a key to that, and next slide, is kind of knowing where the person is in the progression of his or her dementia illness. So think about the person making a sandwich. If you think about it, there may be 4 different levels of capacity. Think of these as stages of capacity. So the first stage is the person makes the sandwich quite fluidly and without help. The second, she does it well, but perhaps needs a little bit of help or a reminder or a cue, but kind of independently. And the third stage can make the sandwich, but really needs guidance or cueing for a number of steps in order to really complete the task. So here, the purpose of the task is fading. The order of sequence needs to be supplied. So you can see there's a decline in the capacity performance. In the fourth stage, the person may be only able to make the sandwich with very detailed step-by-step guidance, maybe handing things or pointing things out, or possibly only as a passive participant. So if you think about these 4 levels of making a sandwich, you could think about them as kind of stages in a dementia illness, which takes us to the next slide. So here, if you think about the 4 stages, the 1, 2, 3, 4 as early, middle, and late stage of a dementia illness, then you can think about the steps that the person might be able to take in any particular task you design. So you might design a task for making an apple pie for someone in that first stage in the early, and there can be lots and lots of steps. The person can move around, get things, put things together kind of on her own. If the person is in the late, middle, or late stage, it's going to be a much more simple, spatially contained task that will perhaps involve one step: peel this apple, or that would be a one-step kind of thing. So this table can be thought of as a kind of a guide to designing a just right challenge, and it can be any task you can imagine. Take into account what's the person's capacity for performance, what stage is the person in, and how does that performance capacity or stage correspond to the size and complexity of the task and to the kind of space within which the task can be performed. And then you can begin to think, so depending on the stage of the person's illness, how shall I provide help? Can I just narrate directions? Do I have to begin to point things out? Do I have to hand things to the person? Do I do things in front of the person and promote passive involvement? So this is a kind of an overview guide to designing a just right challenge. And I think as we get closer to Thanksgiving and continue these Brain Talk Live talks, we're going to focus over the next couple of weeks on using this concept of the Just Right Challenge as a way of moving into the holiday season and engaging your person in holiday activities that are pleasant for the person within his capacity, and kind of gratifying for you as the caregiver, because you can see the person contentedly involved. So that's my Caregiver Essentials presentation for today. Questions? I see lots of questions. Oh, but they're all around medication.
Thank you, Ken. I think that there are some questions in the chat for you. So,
Honestly,
are there any that you think you want to address on screen, Ken, or we can just follow up in email?
I think we should follow up. My particular version of Zoom, quite unusually, doesn't have a chat thing.
Okay, all right.
But
Okay. Dr. Hepburn will be answering your questions in the chat as we go along. Right now, if you think you need to get a little break, refresh yourself, go up and get your glass of water and refresh yourself otherwise. I'm going to do a little recap and then I'm going to introduce our very next speaker. Just to kind of go back over some of the stuff that you've heard a little bit earlier. How do you diagnose dementia? What's involved in examination? Well, first of all, you have to have a comprehensive medical examination. Oh, he's okay. And a comprehensive medical exam, we're going to do a medication review. We're going to review your medical history, the different things you're being treated for. We're going to test you for thyroid disorders, diabetes, syphilis, vitamin tests. We're going to order a special brain image. Now, Dr. Law told you we prefer a brain MRI to a CT scan, but the only FDA-approved radiologic study for diagnosing Alzheimer's specifically is an amyloid PET scan, but that's not available to most of us. So your neurologist, your local neurologist or primary care doctor is to order an MRI. Along with your medication review and a comprehensive medical exam, if all of your healthy metabolic things are all within order and where they're supposed to be and your brain MRI has been conducted, we'll send you to the PhD psychologist, the neuropsychologist, who will do a pen and paper test to figure out what parts of your brain function are working well and which ones are not. Diagnostically, in the neurology clinic, the neurologist is going to do a spinal fluid examination to look for the precursor proteins, A beta and tau proteins right now that give you a diagnosis of Alzheimer's. Now, whether you have Alzheimer's or not, that is a part of their diagnostic procedure. So having symptoms is not a diagnosis. You have to do a whole lot for that. We do a comprehensive medical exam. You have to have a brain image to look at your architecture. You have to have neuropsych examination or testing. And we do a spinal fluid examination. Some centers do that a little differently, but these are the basics. Next. So what kinds of things can you do to maintain brain function? Dr. Law gave you a lot of things that you could do, but we know as per the Lancet Commission's consensus report, there are about 10 different things that you can do to prevent brain dysfunction. One of those is exercise regularly. We have John up here dancing and moving around and getting you to move because exercise is very important to brain health. It's important for controlling weight. It's important for controlling hypertension. Consume a heart-healthy diet, a Mediterranean diet, the MIND diet, which is a combination of the heart diet and the Mediterranean diet. We want you to prevent social isolation, become socially engaged, maintain your connections with your friends, in your church, in your neighborhood. Manage hearing loss. Hearing loss is associated with sensory deficits that may make it a little difficult for you to hear things, to interpret things. So get your hearing tested. Identify and treat depression and mood disorders. Early treatment and management of these things can kind of forestall some of it, but as Dr. Law said, depression and mood disorders can be associated with Alzheimer's development. Engage in regular intellectual activity, play an instrument, read a magazine, do whatever it is that stimulates your intellectual curiosity and maintains things. Evaluate and manage sleep disorders, sleep apnea, oxygen deprivation. These are things that are important for brain health. Manage your chronic diseases. Most people who die with a diagnosis of dementia don't die from the dementia. They die from poorly managed high blood pressure. diabetes, chronic obstructive pulmonary disease, kidney disease, and other chronic diseases, particularly heart disease, that can be significantly debilitating. Avoid obesity. You can avoid obesity by exercising regularly and eating properly, but that's one of the risk factors that's associated with developing dementia later on in life. And then finally, stop smoking. Smoking cessation because it's associated with stroke risk. Next, please. We know that in 2020, we had a whole bunch of studies that were going on. We know that there are over 120 different clinical trials in the country. This is a self-explanatory slide. Clinical research is ongoing all the time. We have a number of different drugs that are in the pipeline or in development for being what we call disease-modifying therapies. Aducanumab or Aduhelm is the first drug that's considered to be a disease-modifying therapy that has been FDA approved for treatment of Alzheimer's. There are others that we're working on. If you meet criteria, join a study. Next, please. Finally, it's really important for everybody to appreciate that dementia is a very different kind of disorder. It's not normal. As you get older, you should have your brain and keep it for as long as you can. Symptoms that go along with dementia may be caused by a medication, an acute illness, or a chronic disease that needs better management. That's why a comprehensive medical examination is an important part of a dementia evaluation. There's several types of dementia, and the types of therapies that are appropriate for one may not be appropriate for another. Right now, there is no prescription that I can write for you that's going to treat or reverse the course of any progressive dementia. We conduct research to help define the disease process, to look at and develop other methods by which we can treat this disease or effectively treat this disease. But research participation, again, I'm going to say this again, research participation is not a substitute for a comprehensive medical examination. So that's the recap for dementia. Okay, I'm going to, at this point in time, just before I introduce our next speaker, Dr. Jonathan Grill, I want to pause for just a minute to acknowledge a couple of people who've made it possible for our programs to be successful for the last 12 years. They are the Atlanta chapter of the Links Incorporated, the Atlanta alumni chapter of Delta Sigma Theta, the AME 6th Episcopal District, specific congregations, Flipper Temple, Big Bethel, Turner Cascade, St. Paul Episcopal Church, the Lou Walker Senior Center, Chi Tau Omega chapter of Alpha Kappa Alpha, Kappa Omega chapter of Alpha Kappa Alpha, the Sigma Zeta Foundation, Ben Hill United Methodist Church, First Congregational Church, Greater Piney Grove Missionary Baptist Church, and the Good Samaritan Health Center. Without these different supporters, community supporters, we wouldn't be as successful as we have been in reaching our community and increasing the number of underrepresented persons in our research. So thank you to these organizations. Thank you to every one of you that has tuned in today. We look forward to your further participation by enrolling in a study of your choice and for which you are eligible for. Our next speaker is Dr. Joshua Grill, who's going to talk to us about healthy aging. He is a professor of psychiatry and human behavior at the University of California, Irvine, and he is a very important member of a lot of our Alzheimer's disease research centers, as well as our National Organizing Coordinating Committee for Alzheimer's Research. Dr. Grill.
Thank you, Dr. Parker. And I want to thank Dr. Parker and Dr. Levey and Dr. Law for the very kind invitation to join you all today. It is not surprising, but very exciting to see such a fantastic turnout for this session.
Atlanta,
and I'm really honored to be a part of it. So I think I'll try to share my screen and show a few slides. And I was asked to talk about prevention today. So hopefully my slides are showing up in show mode. Someone can just kind of unmute and tell me if it's in the wrong mode, but
it looks great.
Great, thank you. What I'm going to try to do is talk a little bit about what we know about Alzheimer's prevention And specifically, I'm going to try to separate myths from facts. So it's a brief talk, but I'm going to try to quickly go over why Alzheimer's, because I think today has already been very thorough in talking about why Alzheimer's is so important and why we'd want to prevent it. And I'll spend the bulk of my time talking about lifestyle risk factors and unfortunately, something that's increasingly common, what others in the field have referred to as pseudo-medicine. And then I'm going to close by where we're going as a field and where the science needs to take us. So again, I think we've heard very eloquently and substantially today that Alzheimer's disease and other causes of dementia are really an important problem. More than 6 million Americans are affected by Alzheimer's disease today. And this has been a problem for a while. And while we've seen other conditions experience improvements in our opportunities to treat and even cure major causes of death and disability in this country, Alzheimer's disease has been steadily rising in its impact. This is illustrated in numerous ways, including the number of people who are dying of Alzheimer's disease each year. It's now the 6th leading cause of death in the United States. And it's actually, this trend is going to increase, which is frightening and warrants the kinds of investments that we're seeing now as a nation in research to try to find ways to better identify, diagnose, and of course, treat Alzheimer's disease. It's important to say that this trend shown here is expected to continue in the coming decades. The reason is that the #1 risk factor for Alzheimer's disease is age, and the fastest growing segment in our population is older people. Almost no matter how you define it, if you define older people as 65 and older, that's the fastest growing segment of our population. If you define it as 90 and older, that's the fastest growing segment of our population. For the first time in human history, we actually have more older people on the planet than younger people, and babies born today have a 50% chance of living to be 100 years old. So this is fantastic news. Science and medicine are doing a great job of helping people live longer, healthier lives, but age-related diseases are going to experience tremendous increases in prevalence and cost. And of course, Alzheimer's disease is an extremely expensive disease. And so we as a field are working extremely hard to find ways to prevent it from happening. Prevention really requires better understanding of why people get Alzheimer's disease. And later today, you'll hear fantastic talks about early onset Alzheimer's disease, in which genetics really plays a key role. This is a complicated slide, and I won't belabor it. It's only to say that we've learned a lot about the genetics of Alzheimer's disease and other dementias. Some genes are associated with greater risks, but are extremely rare. Some are more common, but have a smaller relative impact on risk. And that's all this illustration really says. But the geneticists tell us that taking all this information into account, the many different genes that have been identified as playing some sort of role in who does and does not get Alzheimer's disease, only adds up to about 50% of the total risk for this disease. So if we could fully sequence your genome, and a lot of this work has come from Emory, in fact, it's worth saying, we really still couldn't say who will and will not someday get Alzheimer's disease. And again, we've heard it from Dr. Law, we heard it from Dr. Parker just now. The remaining 50% of risk seems to come from our environment, including our lifestyle choices, how we treat our bodies and how we treat our brains throughout life. And Dr. Parker referenced this Lancet Commission paper, which really has sparked fantastic conversations in our field about how we can harness what we are learning about lifestyle risk factors to try to help people lower their risk for getting Alzheimer's disease. The Lancet Commission that's illustrated here produces an easy list of recommendations that we all can and should make. And these recommendations Dr. Parker outlined for you earlier are not unique to this Lancet Commission. We've seen from the AARP the Global Council on Brain Health, recommendations for improving cognitive function later in life. We've seen from the Alzheimer's Association, 10 ways to love your brain. The World Health Organization has given us risk reduction guidelines, and the American Heart Association and American Stroke Association have similarly produced guidance on ensuring brain health. So there's a number of different slight variations in the types of recommendations that can be made, but overall, these are highly similar. You heard them again from Dr. Parker. Increase your physical activity. John Lewis did a fantastic job to get us started in this regard. This is maybe the single most impactful thing we can do to help our brain health, because it does so many good things for our brain, from increasing our cardiovascular health, increasing our blood flow to our brain, and actually having a direct impact on our brain's physiology as well. We can try to diet away from dementia. We can apply the principles of a Mediterranean diet or a DASH diet, making sure that we eat healthy sources of fat like fish and olive oil and mixed nuts, and avoid the foods that are high in fat and cholesterol. If we're smokers, we should stop. We shouldn't have to tell people that anymore, but we still do. And this is not only bad for our risk of cancer, it's really bad for our risk of getting dementia later in life. Controlling blood pressure, controlling cholesterol, these things that our primary care physicians work closely with us on every year to avoid heart attack and stroke, are also effective ways to try to lower our risk for dementia. Doing cognitively demanding tasks, keeping our brains active, exercising not only our bodies, but exercising our brains as well, can help improve our cognitive function later in life and perhaps lower our risk for developing cognitive problems. And tremendous research has recently shown that the amount and quality of sleep we get is vital to our brain health. Whole systems have been identified that get turned on when we're sleeping that help cleanse our brain of toxic proteins, including that amyloid protein that Dr. La told us about earlier in the session. And so making sure that we're getting a good 7 hours or more of high quality sleep, practicing good sleep hygiene by not using a nightcap to help us sleep, resting and lowering our activities right before bedtime. These things can be critical to improving our brain health. And models suggest that if we can get people to adhere to these recommendations, if we could get people to stop smoking, if we could get people to start exercising, that we could actually have meaningful impact on the public health of dementia. By some estimates, 25% adherence to some of these brain health recommendations could lower the number of cases of dementia in the United States by as many as 500,000. And more than that, the epidemiological studies suggest that these things may already be at play in developed nations like ours, where higher education has become increasingly available, the advent of cholesterol-lowering drugs and antihypertensive medications. All of these things may be producing a slight decrease in the incidence of dementia, the number of people per age group who develop cognitive problems that are disabling. But the prevalence of the disease, because of the growth of older people in our population, will continue to rise. Nevertheless, these are important and exciting hints that these healthy lifestyle choices could actually have an impact on public health, and all the more reason for all of us to do everything we can to try to maintain our brain health as we age. Now, unfortunately, there are people out there who are taking advantage of this information, taking advantage of the desperation some people feel to avoid Alzheimer's disease and other dementias. And our colleague, Joanna Helmuth at the University of California, San Francisco, has really led the way in describing and pointing out the the real problem that exists in the field right now, referred to as pseudo-medicine for dementia. Sadly, today in 2021, there's no way to definitively predict who will and will not get Alzheimer's dementia. And there is no way to, with certainty, prevent it from happening in an individual. We don't have an FDA-approved drug to prevent Alzheimer's disease. There's essentially no evidence to support the use of dietary supplements as a way of preventing Alzheimer's disease. And the recommendations that you've already heard multiple times today around lifestyle choices can, should, have been today made free of charge. You don't need to take expensive classes or buy books or go to hotels for fancy seminars. These are things that we in the Alzheimer's disease field make recommendations freely and as often as possible, because we want everyone to do everything they can to protect their brain health. Similarly, there are groups who will manipulate the system by publishing papers in predatory journals so that they can suggest that they've published results, or even placing things on clinicaltrials.gov to suggest that they're doing a rigorous study. Clinical trials must appear on clinicaltrials.gov, but they should never be including charges to people to participate. We've seen that around here, especially in some of the for-profit stem cell clinics where people suggest they're doing a clinical trial, but it carries a very heavy price tag for individuals to participate. So how can you make sure that you're not falling prey to a scam or pseudo-medicine approach? You're doing it. Talk to people at your local Alzheimer's Disease Research Center. Reach out to the Emory Gazetta ADRC. Look at resources that are known to be of high integrity, like the websites of the ADRC system, or the NIA website, or the Alzheimer's Association website. Make sure before you start any new treatment or spend any amount of money on a preventative approach that you're not making a mistake or falling prey to pseudo-dementia. After that, we as a field have moved very much toward the direction of prevention. You heard Dr. Levey, Dr. La talk about this. Numerous studies are now ongoing that are testing aggressive treatments, like very much like the one you'll hear about in a few moments, including antibody treatments that can actually clear the brain of the amyloid plaques that we've heard about today if the medications are taken at high enough dose for long enough periods of time. I'm part of one such study that's now underway, and it's happening at Emory as well, called the AHEAD study. It's testing a monoclonal antibody, and we're all kind of familiar with antibodies now in the COVID generation. We get vaccinated against the COVID coronavirus in order to raise antibodies to fight against that virus. In Alzheimer's disease as well, antibodies may be key to fighting against those abnormal proteins that accumulate in the brain of a person with Alzheimer's disease. And Dr. La told us earlier that those proteins begin accumulating years, if not decades, before the memory problems begin. The AHEAD study is asking, if we remove those proteins before the memory problems begin, can we prevent a person from ever experiencing memory problems? It's an exciting study. It's going on around the country, including at Emory and many other Alzheimer's centers in the United States. So in conclusion, I've told you that Alzheimer's disease is a major problem in our nation, that the problem is unfortunately going to get worse unless we can develop research solutions. Because it is such a big deal and people are so desperate to make any changes they can, we are all at risk for being susceptible to bad players in the system. And it's up to you to do everything you can to protect your brain health. And if possible, we need people to join us in research studies like the Healthy Brains cohort study Dr. Law talked about, the ADRC at Emory, or prevention clinical trials testing promising aggressive therapies to try to help prevent people from ever developing memory problems and dementia. With that, I'd like to thank you for your attention. Again, thank the folks at Emory for the very kind invitation, and I'd be happy to take any questions.
Thank you so much, Dr. Grill, for that presentation. Please forward your questions to the Q&A such that Dr. Grill can answer the questions. At this time, we're going to move on with our next speaker, Dr. Alfred Sandrock, Jr. He's the Executive Vice President and Head of Research and Development at Biogen Incorporated. Dr. Sandrock, thank you and welcome to the Emory Goizueta Alzheimer's Disease Research Center.
Thank you very much. Thank you, Dr. Parker, for inviting me. Thank you to the organizers for letting me speak today. Next slide, please. Just a brief disclosure. I'm a full-time employee of Biogen and I hold shares in the company and I have some other roles as listed here. Next slide, please. A brief introduction into Biogen. We are the oldest biotechnology company in the world. Next slide. Founded in 1978. We have a very strong emphasis in neuroscience. We're interested in multiple sclerosis, Alzheimer's, ALS, SMA, Parkinson's disease, neuropsychiatry, et cetera, stroke. But I want to next just focus today on Alzheimer's disease and dementia. Next slide, please. Where I'm just going to talk about one program. Next slide, please. I'm going to talk about aducanumab or Aduhelm that was approved in June of this year in the United States and is pending approval, being reviewed in other territories. Briefly mention lecanemab, which is the drug, the antibody against A-beta that is being tested in the AHEAD study that Dr. Grill just mentioned. And we also have, in addition, 2 programs directed against tau. One is a monoclonal antibody and another one is an antisense oligonucleotide. Next slide, please. Just a quick review of the history of Alzheimer's disease. It was first described by Dr. Alzheimer in Germany in 1906. And it really wasn't until the 1990s that we really started to understand more about Alzheimer's disease. First, the amyloid beta protein was discovered to be the main constituent of amyloid plaques that build up in the brains of Alzheimer's patients. There were a bunch of mutations discovered in the 90s related to genes that are involved in some way in the production of A-beta 42 amino acid long peptides, either the amyloid precursor protein gene itself, or they encode gene products that are enzymes that cut the amyloid precursor protein into the A-beta 42 fragment, which then tends to be very aggregating. And when they form these clumps of proteins, they can be deposited in amyloid plaques. We did have some drugs approved, cholinesterase inhibitors and memantine, but no drug has been approved since 2003. And then I should also note that, as Dr. Grill mentioned, there are mutations, for example, this Icelandic mutation that can decrease the risk of Alzheimer's disease. This one in particular affects the way amyloid precursor protein is cut into these 42 amino acid peptides. Next slide. So a lot of genetic evidence pointing to A-beta protein. And of course, in addition to that, what we know is when we look at the brains of Alzheimer's disease patients, not only do you get a lot of brain atrophy or loss of tissue, but when you look under a microscope slide, you see amyloid plaques, which are these clumps of proteins containing A-beta protein, as well as tangles inside neurons that have a high predominance of another protein, a different protein called tau, in particular phosphorylated forms of tau. And that's why Biogen and many other companies are targeting these two proteins, A beta and tau, because there's a lot of evidence that points to them as being involved in the pathology or pathophysiology of Alzheimer's disease. Next slide, please. Moreover, we know that if the disease starts here at this green arrow going down, where people have mild cognitive impairment as shown thereby as MCI, that's when people start to exhibit symptoms and signs associated with Alzheimer's disease dementia. What we know is that many years prior to the onset of those first symptoms, we see abnormalities in A beta protein biomarkers, for example, in the spinal fluid. And then after that, it looks like there's an accumulation of tau, abnormal tau proteins. So these proteins get laid down and start to be deposited in the brain long before first symptoms. And of course, the timing is also consistent with the idea that they are causal, because they start to develop abnormalities long before first symptoms appear. And so we now think of Alzheimer's disease as a continuum where we have these changes biologically that precede the cognitive impairment that you see in green there. Next slide, please. Just to now I want to talk about aducanumab. The drug that I just mentioned was approved by FDA in June of this year. This antibody actually comes from human donors. So these are either people who were aging very, very well, healthy agers, as the slide shows there, or people with Alzheimer's disease that have an unusually slow disease progression. And it turns out that this company Neurimmune, as shown in the upper right, looked into why that is. They found that there were B cells, these cells that produce antibodies, that made antibodies against very high affinity antibodies against the clumped up proteins of A beta. And so they specifically looked for these cells that can recognize the aggregated, but not the normal monomeric forms of A beta, and selected those cells that produce those antibodies, cloned those cells, and this is where aducanumab comes from. Next slide. So it's almost as if the body had a natural reaction by forming antibodies against this abnormal protein. And so aducanumab was licensed by Biogen from Neurimmune in 2007, and after multiple preclinical studies, we began first in human phase 1A studies in 2011, and after multiple clinical trials, it took 10 years before aducanumab was approved by FDA earlier this year. Next slide, please. So one of the first human studies we did, a study that we call a phase 1B study, or PRIME, which was published in Nature in 2016, we looked to see whether or not this antibody, when given intravenously to patients with early Alzheimer's disease, whether that could remove the amyloid plaques, which we believe are toxic in the brain. And so we used amyloid PET scans in order to see whether or not the antibody could remove the amyloid plaques from human brains in people suffering from early onset, early Alzheimer's disease, early stages of Alzheimer's disease. And so, for example, on the left side of this graph here, you see the baseline scans from 4 different patients from 4 different groups in the study. And you see that there's a lot of red there on the left side, which means that there's a high concentration of amyloid plaques in the brain. Then we looked 1 year after treatment with the antibody. And we looked at placebo treatment. And as you can see across the top row, there's no change in the red. But if we go to 3 milligrams per kilogram IV once monthly versus 6 milligrams per kilogram IV once monthly versus 10 milligrams per kilogram IV once monthly, we see a dose-dependent decrease in the red color. In other words, the antibody was removing the amyloid plaques from the brain of patients with early Alzheimer's disease. So based on this study, we actually also saw in the study trends toward improvement or slowing of clinical decline in patients who got the higher and higher doses, especially those who had 10 milligrams per kilogram. So the next slide shows that we did 2 large global phase 3 trials. These were 18-month studies. We studied over 3,000 patients at 348 centers in 20 different countries around the world, as you can see on the right. The patients enrolled in this study had early Alzheimer's disease, either mild cognitive impairment due to Alzheimer's disease or mild Alzheimer's disease dementia, and they had certain scores of in certain rating scales. And what we tested was a low dose of aducanumab, a high dose of aducanumab, and placebo randomized in a 1-to-1-to-1 fashion. The primary endpoint was the CDR sum of boxes. CDR stands for clinical dementia rating. So we were looking at whether or not the rate of decline in the dementia score was affected by antibody treatment relative to placebo. And we looked at a number of secondary endpoints. Next slide shows you some of these endpoints. So the clinical assessments as are shown in this slide. So we looked at cognitive function by looking at the mini mental status examination, as well as the ADAS-Cog13, which ADAS-Cog stands for Alzheimer's Disease Assessment Scale, cognitive subscale. We looked at function, and here we're looking at activities of daily living using the ADCS-ADL-MCI. And then in addition, as you can see in the green on the right, the CDR sum of boxes looks at both cognition and function. So we had scales that looked only at cognition, we had scales that looked only at function, and the CDR sum of boxes combines an assessment of cognition and function. And we also assessed behavior using the Neuropsychiatric Index 10. And I will tell you that we had as I said earlier, there were 2 large phase 3 trials, that one of the phase 3 trials was positive on all these endpoints. The other trial, though, was not positive. And so that's what led to some of the controversy you may be hearing about in the news, that one trial was positive and one trial was negative. So we spent about almost 2 years, we meaning Biogen in collaboration with FDA, to try to understand what caused that discrepancy in the 2 trials. And after much work, the FDA determined that that it was likely that the drug did have efficacy, but it needed to be confirmed. And so it was approved under an accelerated approval pathway with a confirmatory study being required. And I'll mention that again in a subsequent slide. Next slide, please. In addition to these clinical measurements, we looked at biomarker measurements. So we did PET imaging again. And this time we looked not only at amyloid PET imaging using this AB45 PET ligand, but we also looked at tau PET imaging. So we wanted to see if the other pathological feature, in addition to amyloid plaques, whether the other feature, the neurofibrillary tangles containing abnormal forms of tau, could also be affected by treatment. And then we also looked in spinal fluid at tau. And actually the package insert for aducanumab does contain data from all of these markers, as I showed in the slide, on the title of this slide. And I can tell you that there were effects, dose-dependent effects, on all of these biomarker measurements as depicted in the package insert. Next slide. So as I said, Aduhelm was approved by FDA on June 7th. And I just want to show you the indications and usage. I'm not going to show the entire package insert, but I want to show you this and a couple of other things. It says that the Aduhelm is indicated for the treatment of Alzheimer's disease. Treatment with Aduhelm should be initiated in patients with mild cognitive impairment or the mild dementia stage of disease, the population in which treatment was initiated in the clinical trials, as I told you earlier. There are no safety or effectiveness data on initiating treatment at earlier or later stages of disease than were studied. This indication is approved under this accelerated approval pathway based on the reduction in amyloid plaques observed in patients treated with Aduhelm, and that continued approval for this indication may be contingent upon verification of the clinical benefit in a confirmatory trial, which is about to start, that we're conducting. Next slide, please. I do want to mention that in addition to the benefits that I described in the previous slides, as with many medicines, there are risks. And the most important risk associated with Aduhelm is called ARIA, or amyloid-related imaging abnormalities. And because of this risk, the FDA label stipulates that in addition to getting a baseline scan prior to starting aducanumab, that 2 other scans get done within the first year of treatment, prior to the 7th infusion and prior to the 12th infusion. And that if there's 10 or more new incident microhemorrhages or more than 2 focal areas of superficial siderosis, then things have to happen as shown on the right. There are recommendations in terms of stopping treatment, pausing the treatment, reducing the dose for a period. And this was actually very similar to what we did in the clinical trials. I should say that at the dose that was approved, which is 10 milligrams per kilogram, ARIA-E was observed in 35% of patients treated with Aduhelm, and that ARIA-E or H was observed in 41% of patients treated with Aduhelm. Typically, most of the time, these ARIA-E and ARIA-H events were asymptomatic. About 75% of the time, they produced no symptoms, but occasionally they did produce symptoms. And 0.3% of the time, those symptoms could be severe, including seizure. So I wanted to be sure that you understood that in addition to some of the benefits that are described in the label, that there's also this risk of ARIA that needs to be monitored for. Next slide, please. It contained in the label are the effects in the all three studies showed a robust reduction in amyloid plaque burden. And the third study here way on the right is the PRIME study that I showed you the pictures of, and the 2 figures on the left are from the phase 3 trials. I'll say that the reduction in amyloid was a little bit less in the trial that did not produce a statistically significant effect on the cognitive, functional, and outcomes, but the trial that was positive on all those endpoints did produce a more robust reduction in amyloid. So we think that was important. Next slide, please. In fact, I want to show this slide, which is in the FDA website, which is part of the aducanumab approval package. This comes from the Office of Clinical Pharmacology. And what they're plotting is the cumulative dose on the x-axis versus the SUVR on the y-axis. And SUVR is a quantification of the redness, if you will, in the amyloid plaque. And as you can see, if you get 0 drug, you have a high SUVR score of around 1.4. And that as you progress along the right, as you get more and more drug, you see less and less amyloid in the brain as measured by SUVR. And I want to point out this dotted line around 1.1. That's an important number because 1.1 is the cutoff between normal and abnormal PET scans. So if you're below 1.1 and you get a PET scan today and you're below 1.1, that would be considered a normal amyloid PET scan. If you're above 1.1, that's considered abnormal. So you can see that by the time you accumulate high doses of aducanumab, you get very, very close. Or in the case of the positive study, 302, you actually dip a little bit below the dotted line. So that was very important to show that there was a relationship between the cumulative drug exposure or the cumulative dose and the removal of amyloid. Next slide, please. Moreover, the same office in the same set of documents plotted the relationship between amyloid removal on the x-axis now, and the group level mean difference from placebo on the clinical dementia rating scale. So as you see on there, 0.0, some drugs that had been tested previously, like solanezumab and crenezumab, had no significant reduction in SUVR score in amyloid plaque, and they also produced essentially no change from placebo on the CDR sum of boxes, as you can see by 0. But as you move toward the left and you see a reduction from placebo on the amyloid plaque burden, you start to see separation from placebo on the CDR sum of boxes. And it's only when you get toward the left when you can remove more amyloid. So it seems to be that you need to have a greater reduction of amyloid to get the effect on the slowing of clinical decline on the CDR sum of boxes. And so this slide summarizes data from 6 different antibodies. Only one of these, aducanumab, is approved now, but BAN2401, which is the other name for lecanemab, and donanemab and some other antibodies that are very effective at removing amyloid are currently in clinical trials. And we hope that there will be other drugs like aducanumab, such as lecanemab or gantenerumab or donanemab, that can also produce a slowing of clinical decline. Next slide, please. So I just want to end by saying that we're very interested in seeing whether or not we can monitor brain health using an Apple Watch. We have teamed up with Apple, where they can, just by how you use your iPhone and by the Apple Watch. So it's really mainly the iPhone, but also the Apple Watch. Just how you use your iPhone. You don't have to do any special performance things on it, but just how you use your iPhone and what the watch detects may actually detect mild cognitive impairment very early. And so if successful, these digital biomarkers may accelerate the diagnosis of mild cognitive impairment. Hopefully that will lead to improved patient outcomes and greater understanding of cognition. So we announced this collaboration earlier this year, and we have launched a study, a large study that's going to look at whether or not the iPhone and the Apple Watch can detect mild cognitive impairment. Next slide. I want to talk about the fact that in the future, I agree with Dr. Grill, there's no way to prevent Alzheimer's disease at present, but there are some interesting studies like the AHEAD 3-4-5 study that he talked about, testing lecanemab. I believe in the future we'll combine genetics with precision phenotyping, and the precision phenotyping can come in the form of blood tests. And there are already blood tests that people are working on that can detect amyloid and even tau in a very similar way to spinal taps or PET scans. Wouldn't it be great if we could just do a blood test to know whether or not amyloid or tau were accumulating in the brain? And it looks like the early data does suggest that some of these blood tests can detect early deposition of abnormal proteins like amyloid and tau in the brain. And if you combine that with genetics, then maybe we can recognize people who are at high risk and treat early and prevent the disease. That would be a wonderful hope, because I think then we may be able to delay the onset of the diagnosis of Alzheimer's, or maybe even prevent it altogether one day in the future. Next slide, please. So with that, I want to just thank all the people who participated in the aducanumab clinical trials, our steering committee, data monitoring committees, all the clinical investigators, pharmacists, coordinators, radiologists, the Alzheimer's disease research community, our partners, companies, Neurimmune and ASI, the Biogen R&D team, and my many mentors, colleagues, and teachers. Thank you.
Thank you so much, Dr. Sandrock. At this time, we will entertain 1 or 2 questions. And there is a question specifically for Dr. Sandrock with respect to the cost of aducanumab, and why are we not making Aduhelm available much like they are COVID vaccines, free?
Yeah, well, I'm hoping that that the CMS, the group that manages Medicare, will make a national coverage determination that will make it so that anybody who's on Medicare can have access to the drug without significant out-of-pocket payments. But these clinical trials that we conducted cost about $1 billion just to do the clinical trials. And so, for companies to need to be able to take the risk of failure and investing in these expensive research and development programs, companies need to be able to see some return on investment.
Thank you so much for that answer. Dr. Law?
Regarding cost, can you mute that?
The next question is, did patients show significant improvement after using aducanumab?
Did patients show significant improvement after using aducanumab?
What we notice is that the main thing we notice is that patients have a slower rate of worsening. But at the FDA advisory committee, there were some patients who reported the ability to do things that they weren't able to do before. And these were patient testimonials. And I've heard this from many of the clinical trial participants, but that's not what our data shows. Our data shows essentially, mainly what our data shows is that we slow the rate of clinical decline by removal of amyloid plaque. And of course, we need to verify that we do see that, because as I said, we had one positive trial and one negative trial. So we're doing a confirmatory study now to be sure of that.
Yeah, so as Dr. Sandrock has indicated, the really promising aspect, am I okay? Okay. The very promising aspect of this and other emerging therapies is the possibility that they may slow down the progression of disease. But we did the trial here, and we participated in the study that actually showed a positive signal and appeared to perhaps slow down the decline in patients. But it is really important for our audience to understand that the primary results from the clinical trials were absolutely mixed. So of the two trials, which were equally sized and equally powered and almost identically designed, one study clearly showed a positive response and one study clearly did not. And so the accelerated approval has been extremely controversial from that standpoint. In fact, many health systems have chosen not to put aducanumab on their formularies. Emory has not yet rendered a final decision on that, but it's entirely possible that our health system will also decide the same thing based on the weakness of the existing clinical data. I don't necessarily agree with that, but I do think that we need to be extremely conservative in how we approach this based on the strength of the clinical evidence, the risk that's potentially associated with improper use of this drug, and the very substantial cost. So, in addition to the drug costs, there's also the costs associated with frequent monitoring. We believe that MRI safety monitoring needs to be done more frequently than what is labeled. The Medicare, CMS, and insurers have not made any indication of whether they will approve the cost of associated amyloid PET scans, which, if we're going to follow the design of the clinical trials, really should be how we do an assessment of the effectiveness of the drug for the surrogate endpoint, which is the removal of the amyloid plaques. We can do spinal fluid tests, but it won't give us exactly the same information. So there are a lot of problems with implementing the use of this drug in clinical practice. I view this as an important advance, and I think that it's inevitable that other drugs that are in the pipeline will likewise come to the clinical marketplace. So we need to be prepared for this, but I think we also need to be very realistic that the clinical evidence is still out there. The answer to whether or not aducanumab is truly effective is still up for debate. And there are serious safety and cost considerations that have to be weighed as we start to approach this potentially very exciting and hopeful era of treatment.
Dr. La. Thank you again, Dr. Sandrock. Thank you all for taking time out for attending our 21st annual forum. Our final speaker is Dr. Liana Apostolova, who conducts the lead study out of Indiana University. It is a nationwide study being conducted in all of our Alzheimer's disease research centers. And this study has to do with early onset Alzheimer's disease. Dr. Apostolova.
Thank you so much. Can you guys hear me?
Yes, we can. You sound great.
Good. Do we have to stop at 3 o'clock sharp? But there are 8 minutes left.
You continue on. Go ahead.
Is that okay? Okay. All right. All right, so I'm going to talk to you about early onset Alzheimer's disease. It's a rare variant of Alzheimer's disease, which affects people under the age of 65. And it doesn't mean when we also use the terminology early onset Alzheimer's disease, and by that we don't mean mild stages of disease or early stages of disease. Individuals with young onset Alzheimer's, just like the late onset Alzheimer's, go through all the stages of Alzheimer's disease. And of all Alzheimer's disease patients in the United States, only about 4% have this rare variant. So if we look at what is being, first, let's look at the left plot, please. And here is how common late onset Alzheimer's disease is. This is 97% or 96, 97% of everyone who carries a diagnosis of Alzheimer's disease in the United States has late onset disease, with 65 to 74 in orange, 75 to 84 in blue, and 85 plus in green. The sliver of the pie that is purple are those who are younger than 65. The older individuals have long been followed in a very robust study, observational project called the Alzheimer's Disease Neuroimaging Initiative, which has been existing since 2004. Now let's look to the right graph here. And now we are only looking at the early onset individuals, and those are split in those who have familial history of Alzheimer's disease, 54%, sporadic, which is the first case in the family, about 40%, and only about 6% are those who carry a gene mutation that is given from one generation to the next. There is the false belief that young onset Alzheimer's is always autosomal dominant, but only 6% are. And the remaining, and these who are autosomal dominant have another wonderful study to land in called the Dominantly Inherited Alzheimer's Disease Network, or DIAN. There was no research being done to follow and observationally define early onset AD that is not autosomal dominant until we proposed the LEADS, the Longitudinal Early Onset Alzheimer's Disease Study. So the goal is to study this relatively rare and understudied Alzheimer's disease variant in middle-aged individuals. This is an atypical disease variant, only about 3–4% have it. And it's not only, it starts young, but it also is more aggressive than the late onset. On average, these folks progress much faster than the late onset counterparts. And also, you probably have heard about the major genetic risk factor for sporadic Alzheimer's disease, ApoE4. In young onset, the effect of ApoE4 is much weaker. So there are other genetic markers yet to be determined, just as Dr. Grill mentioned in the 2 talks before me. So why is it important to study this disease? Because for these individuals, getting an accurate diagnosis is impossible. We diagnosed them 3–4 years after they've actually started declining. First and foremost, because there is the misconception dementia is a condition of older people among physicians, because the symptoms that these individuals have may be incorrectly attributed to menopause, stress, psychiatric disorders, stroke, many other things that are more common in middle-aged individuals. So dementia is not on the forefront, because they often also go from a doctor to doctor, and they can get multiple and conflicting diagnoses until they finally reach a dementia expert. And this process can be long, difficult, and frustrating. So part of what we wanted to do is to better define this variant of the disease. The impact of this disease on the families and the patients is tremendous. They're middle-aged, so they're still working, and many of them are the breadwinners for the family. But with this disease, just, it's relentlessly progressing. We still don't have a medication, aside from aducanumab that you heard, that could potentially slow it down. So eventually they lose their jobs. They're no longer able to perform job functions. They get terminated from one or multiple jobs, and they lose self-esteem, confidence, their identity, and their value as an employee and a coworker. There is also financial loss of income. And the families are, these families have young children. They might not be well set financially, though they might be having mortgage to pay, car payments to make, loans and debts. And in addition to that, it totally changes their plans for the future. It's time for legal financial planning. It's very difficult at this young age to find medical insurance. They can get on Medicare, but that takes a couple of years. They are not yet ready to retire, don't have savings for that, and many of their kids are in college. And of course, within the family, the roles and relationships change. We've been talking about the sandwich generation, where a child of a late onset parent would have to take care of the parent as well as the children that he or she are raising. And here it's even worse, because they could still have an affected parent. Now they have an affected spouse, and they still have to raise the children. So the load is enormous. Of course, children can become caretakers, which is really sad to see, but it's the reality. And the impact is on multiple generations and totally changes family dynamics, as I mentioned. It leads to the family being isolated too, not just the individual. So recognizing the huge impact of this not well-studied form of Alzheimer's, we submitted a proposal, the Longitudinal Early Onset Alzheimer's Disease Study, or LEADS, and were successfully funded by the NIA. I'm the principal investigator. My co-PIs or principal investigators are Gil Rabinovich, Brad Dickerson, and Maria Carrillo. The goals of the study are to define early onset Alzheimer's and all its variants, to understand disease progression, to derive important clinical, functional, and biomarker metrics for clinical trials in the early onset population, understand the impact and unique challenges of younger onset Alzheimer's participants, and also with the help of the Alzheimer's Association, identify resources available to assist individuals with younger onset cognitive impairment. Here is a map of all of our sites, and Emory University is a site, and they're about to start enrolling soon, which is super exciting. So if you know of somebody who's eligible, do not hesitate to contact them. There is, why is it meaningful to do this for early onset Alzheimer's disease? Because more common than in late onset, we see the atypical variants of Alzheimer's. So in general, Alzheimer's affects memory first and slowly progresses to affect all other aspects of cognition and function. In early onset individuals, more so than late onset, we see rare variants. One of them is the posterior cortical atrophy variant or visual variant of Alzheimer's disease that completely distorts one's vision, yet there is no problem with the eyes themselves. The problem is in the brain not processing the information. There is a behavioral dysexecutive variant that these individuals have difficulty planning, multitasking, executing tasks at work. Then there is the aphasia variant, and that's a language variant of Alzheimer's, where individuals lose their ability to speak. And all of these variants affect the brain much differently. The memory predominant Alzheimer's disease variant attacks the hippocampal, the medial temporal lobes here. These are the memory recording stations of the brain are located right in this part, while posterior cortical atrophy, or the visual variant you see, affects very different part of the brain most significantly. The language variant, again, the language fields in the brain of a person on the left hemisphere Sorry about that. And the behavioral variant affects the frontal lobes, which are the executive seat for the brain. So just to give you an example from the lead study, here are some of our participants that show these sort of patterns. And here are two maps. What you see on the right is brain atrophy, so shrinkage of the brain. And this is the pattern of shrinkage of the brain that we see in somebody with the memory variant of Alzheimer's disease in our study. Right next to it is deposition of the tau protein, which is one of the two proteins that affect somebody with Alzheimer's. And what we can see throughout those images, they look very much alike. Tau drives atrophy. So what we see here is that the disease is fairly symmetric. The left and the right hemisphere look about the same. The pattern, as you can see, is as you see it. And then in the logopenic variant, which is the young onset language variant for Alzheimer's disease, we see something really significantly different. What we see is that the left hemisphere of the brain is affected much more than the right hemisphere of the brain. This is the left, this is the right. And in posterior cortical atrophy or visual variant of Alzheimer's, what we see is that the visual parts of the brain, the back of the brain, where vision is processed, is affected most heavily relative to the other variants. And here, compare this visual variant with how it looks in this area of the brain to the amnestic variant, where that area of the brain is actually pretty spared. So we also, of course, want to study the genetic heterogeneity in early onset to define some new genetic signals. There is stronger role that genetics plays in early onset compared to late onset. So they are enriched for yet unknown genetic risk factors. Fewer early onset compared to late onset carry the ApoE4 gene, as I already mentioned. And why is this important? Because genetics can really provide very important clues to even future therapeutics. Here is a case from an autosomal dominant case of Alzheimer's disease from a family that has this mutation that goes from one family to the next. So the average person in this family succumbs to cognitive decline or develops mild cognitive impairment around the age of 45. And this is an individual around that age from that family. And next to it is another individual. This is a woman who developed mild cognitive impairment in her 70s, even though she's carrying the gene. And when you have this gene, you obligatory develop Alzheimer's disease at around the age of 45, but somehow this lady escaped. So first and foremost, she had actually more amyloid deposition in her brain compared to the younger individual with this form of Alzheimer's. However, when we looked further, the researchers looked further, they saw that there is much very normal metabolism in an area of the brain that is right here. Look at the difference between the younger individual and this lady. So she had preserved brain function, and that means a lot. And so further research was done on her specifically, and what was found is that besides the mutation she carries, she also has a mutation, a unique mutation, rare mutation in her ApoE4 gene, so that she was resilient. And this is important information because we could, in the future, have genetic treatments for Alzheimer's, or we could study the mechanisms downstream for her, from her very lucky mutation in the ApoE4 gene to understand where we need to intervene. And just briefly, I want to mention where we are going with the lead study soon. And we're going to first internationally, we're going to have 5 sites first in Argentina, then in London, here's the Netherlands, here is Sweden, and also, sorry, here's London, here's Barcelona. So these are our 5 new partners that will join us hopefully next year. And in addition to that, we're going to have clinical trials in this population. It's very important to introduce clinical trials, not only because we really don't know when these individuals are not included in clinical trials, we really don't know if that drug is going to work for them as well as it works for late onset, but also because they're free of other diseases and there is much less noise. For instance, in the elderly, there is so much other pathology going on. There is vascular disease, there is deposition of different proteins. They might not be in good general health, so their brain health might suffer as well. However, these individuals are younger, so they don't have all these concomitant complicating factors that the late onset individuals have. And as I mentioned, unfortunately, this disease variant progresses faster. So we will need, we'll be able to faster test treatments in this population. So here's our website in case you want to go and look around. Of course, please communicate with the Emory site should you know somebody that can participate. We are disproportionately Caucasian in Leeds, which is very unfortunate. So because only if we study African Americans do we know how, just as I mentioned, for early onset, the drugs that treat late onset might not work for early onset. The drugs that are tested in whites might not apply as well. The effect might not be as powerful in other races. So it's very important to include individuals from all racial groups and ethnicity groups as well. And with that, I thank you for your attention, and I'm here to answer questions.
Thank you, Dr. Apostolova. I'm trying to see if we have a question for her. I know we're moving through things. We still have over 500 people here who have enjoyed your presentation. Thank you. And more importantly, I wanted to make sure that our audience was aware of the fact that we do have studies on early onset Alzheimer's disease. And remember, early onset is disease that manifests itself before the age of 65. This is not for your older parents. This is for, as Dr. Apostolova indicated, people who are actively working, people who you wouldn't think might have this kind of disorder. I think that there are a few questions in the chat. I just looking at my assistants here. Do we have any special questions for her?
What about genetic studies in high-risk families?
The question is, are there special studies for genetic studies for high-risk families with early onset Alzheimer's?
Oh, absolutely. So if there are individuals who have APOE4, there are some studies that study exclusively in families enriched with APOE4. If individuals have one of the other mutations that obligatory causes Alzheimer's disease by a certain age, there are studies, the Diane study can host them. So yeah, absolutely, that you have to reach out to Emory and they'll be able to direct you properly to the appropriate study. I do see a question about
the lead study open only to those persons with mild cognitive impairment, or can you be a normal cognitive person?
Oh gosh, so we just about closed enrollment for cognitively normal participants. We have few spots open from African American participants. We would want to study a few more of those. So if you are African American between the ages of 60 and 65, we're really going for a little older, do connect with Emory so they can reserve one of the few last spots that we have left in the study.
Okay, I think that there are a few more questions in chat, Dr. Apostolova, that I think you may be able to answer specifically. At this time, we are a little over. We thank you so much for bearing with us for 10 minutes. We're 10 minutes over. Mr. Matt Dworin from our Cognitive Empowerment Program does want to give you a lead-in for our Cognitive Empowerment Program. But this concludes our formal brain health program.
Thank you so much.
Please complete your surveys at the end. Matt?
Thanks, guys, and great presentation. So in a few minutes, if anyone would like to have a little sample of the Cognitive Empowerment Program, we're going to be starting the Cognitive Empowerment live webinar. Today, we're going to be joined by Brianna Carter and a few other members of our occupational therapists here. And we're going to be talking about technology and accessibility with different devices. So if you're interested in hearing more about that, I'll post a link to register for our webinar, and it's going to be right now as soon as you guys drop off, and we do this every week after Brain Talk Live. So if you guys are interested, please come join us. Thank you.